and before that, it is a part of Johnson and Johnson. See, so our mission is to advance the power of diagnostics for a healthier future for all. So you are all aware about orthoclinical diagnostics or the Quiedel Ortho. It's more than 81 years old organization with the introduction of first the anti-sera anti-D for doing the blood grouping. So we are well associated with the transfusion medicine fraternity with the various solutions in our endeavor of providing safe, compatible blood and blood components to the needy patients. We have our customers in more than 140 countries. So in the year 2022, Ortho Clinical Diagnostics and Quiedel Corporation, who are pioneer in this POCT as well as the molecular testing for COVID-19, as well as for the cardiac and various other markers. So 2022, our name was registered as Quiedel Ortho. So we have the various innovative products. And today we are going to discuss about this phenotype matched blood units. We are all about the antibodies. So two types of antibodies which are very important in the field of transfusion medicine. One is the expected antibodies and another one is the unexpected antibodies. The expected antibodies are naturally occurring antibodies like anti-A, anti-B, anti-H in case of Bombay phenotype cases. Whereas all other antibodies are unexpected antibodies, which is not routinely expected, but they may present because of immunization with the red cell antigens. Maybe because of blood transfusion or organ transplantations or because of pregnancy. So that's called as the alloimmunization. So alloimmunization leads to the development of the so-called unexpected antibodies, which may be clinically significant, which can impact the transfusion. So this alloimmunization can occur because of one is blood transfusions, because we are introducing the blood and blood components which are having various antigens to the patients who may or may not have those antigens. If they are not having those antigens, that antigens may become foreign antigen for those patients who are receiving the blood and blood components, and their immune systems may get triggered and produce the antibodies. It can also occur because of bone marrow transplantation or solid organ transplantation, because these red cell antigens may be present in the bone marrow as well as the organs. In case of females, during the course of pregnancy, when they are bearing the child blood may be different from the mother's blood because these antigens are genetically derived from both parents. So mother may get exposed to the fetal red cells either because of fetal hemorrhage or because of during the delivery, and their immune systems may recognize those antigens as a foreign and produce antibodies. They are called as the alloantibodies. And also we are aware that sometimes the antibodies may develop against the self antigens called as the autoantibodies in case of autoimmune disease. One of the important is your autoimmune hemolytic anemia cases. So we are aware that we do blood grouping, both forward and reverse. So A group, for example, the donor is A positive and the recipient is also A positive. So in the ABO grouping A as well as in the RH group, D is positive. So we also do the compatibility testing like cross match and issue the blood for transfusions. But unfortunately, this donor is the RH phenotype is R2R2 and the recipient is R1R1, which means the donor is having the RH antigens like E antigen, whereas the recipient is lacking the E antigen. Now, when this blood is entered into his circulation, the E antigen, the donor red cells, is considered as a foreign antigen. The recipient immune system recognize that E antigen as a foreign and start developing the antibodies. That's called as the alloimmunization. So initially it is a primary immune response. So the level of antibody may be low, which may be of IgM type. And later, similar situation occurs if the patient receives the E antigen. Maybe the antibody levels are gone down. So compatibility or the cross match showed compatible. But when issue the blood, so the memory cells are there, which gets triggered by the again exposure to the E antigen. That is the donor who is R2R2. That can lead to the secondary immune response, lead to high level of alloantibodies. So this way, transfusion can lead to the alloimmunization. Similarly, pregnancy also. So there is maybe variation between the fetus and the mother. For example, mother is Rh negative and the fetus is Rh positive. So during the pregnancy, maybe because of fetal-maternal hemorrhage or during delivery, some of the fetal red cells enter into the mother's circulation. So mother's immune system recognize this as a foreign antigen and start developing the antibodies. So which is predominantly of IgM type. So usually they may not cross the placenta. So the first baby is always safe. During the next pregnancy, if something happened that can lead to the secondary immune response. So this time it is a predominantly IgG type, which can cross the placenta and affect the fetus, leading to this hemolytic disease of the fetus or the newborn. Which antibodies are clinically significant? You have to assume all, which can react at the body temperature, which may lead to the binding to the red blood cells, which can lead to the hemolysis of the RBCs. So all are considered as a clinically significant. In that, some of the antibodies like Lewis, anti-P antibody may be less clinically significant. So what will happen if we develop these alloantibodies? So these antibodies can bind to the RBC. Maybe if the patient is having a immunized, so it can bind onto the donor red cells. And those donor red cells, once it is binding, lead to the hemolysis, which may lead to the hemolytic anemia. Because of this lysis of RBCs more, so kidney has to do overwork, which may lead to the kidney failure, and sometimes it can be a fatal also. So once we develop those, patient is developed those alloantibodies, sometimes it can be single. We may be able to get the compatible blood units while doing cross match. Sometimes if it is a multiple antibodies are there, difficult to get the compatible blood units. In case of pregnancy also, it can lead to the complications to the fetus as well as the newborn. Because sometimes if it is affect the fetus, the mother will feel very bad that my blood is killing my baby. That can give the a lot of emotional stress. So what is the prevalence of these unexpected antibodies? Generally, it is less. In the general hospital patients, maximum it can go up to 1 to 2%. In case of multi-transfusion patients or multiparous mother, the alloimmunization can occur up to 5%. In case of transfusion dependent disease like thalassemia, sickle cell anemia, the prevalence may go up to maximum 30%. If you see that the prevalence is majorly it is of RH followed by the other antigens. In India, we are finding more of RH followed by the M, as we may not have much KEL antibodies. So this is one of the study where they analyzed the donors and the general patients. So the maximum number of antibodies are found with a RHD antigen followed by anti-E, then anti-small c, so as well as the anti-K, then anti-M, anti-S. So what is this clinical relevance of these alloantibodies? These antibodies may be of IgM type or it may be of IgG type. They can lead to the destruction of RBCs, both intravascular as well as the extravascular. So because of the presence of these alloantibodies, it can complicate the transfusion therapy. Because we give transfusion, already the patient is anemia. So we issue the blood units so that his anemic conditions can be overcome. So instead of surviving for a particular period, it will be a short survival of RBCs. So it can lead to other complications. So which we call it as a hemolytic transfusion reactions, which may be mild or it can be in extreme cases, it can be a fatal also. So these are either the IgM or IgG mediated destruction of RBCs. And sometimes it can also suppress the erythropoiesis by promoting the immune destruction of erythroid progenitor cells. So if you see that there are various types of clinical conditions like acute hemolytic transfusion reaction, delayed hemolytic transfusion reaction. In case of newborn or the fetus, hemolytic disease of the fetus and newborn. Sometimes it can be febrile, allergic transfusion reactions, PTP, TRALI, GVHD. So various types of clinical situations it can occur because of this, the presence of these alloantibodies. Acute hemolytic transfusion reaction, where the donor RBCs are get lysed both intravascularly or extravascularly because of the presence of the circulating antibody, which can lead to various symptoms. Also, it can lead to tachycardia, or in some cases, it may be a fatal death and also. So delayed hemolytic reactions, which may occur, the person got transfused. So initially there was no any issues, but after a week, it starts showing complications. That's called as the delayed hemolytic transfusion reaction. Again, it is having various symptoms like cola colored urine, anemia, bilirubin levels are increasing. We also aware about this hemolytic disease of fetus and newborn. If the mother is having alloimmunized, if it is not monitored, so it can affect the fetus. Fetus red cells may get affected and they can lead to the jaundice, that is hyperbilirubinemia. Also, it can lead to Can I request others to keep it in mute? Thank you. So erythroblastosis or fetalis or hydrops fetalis, it can occur. So the next question comes, how we can able to minimize those alloimmunization? Because we have seen that the alloimmunization is the variation in the antigens between the donor and the recipient. Mostly we do the ABO blood grouping as well as the RH blood grouping. In that also only the D antigen we do the phenotyping and issue the blood when there is a both the donor and patients are ABO and RH matched, and we do the compatibility testing called as a cross match. Sometimes these antibodies may get missed in the cross match, and the red cells are having other than ABO and RH. In the RH itself, there are 5 different antigens, plus additionally other blood group systems like Kel, Duffy, K, MNS, Lewis, Lutheran, P. So we are not routinely verifying whether both are matching or not. In such a cases, there can be a variation between the donor and the recipient that may lead to the elimination, which is very common in case of multi-transfusion patients like sickle cell anemia and thalassemia, because they need lifelong transfusion support. So in those cases, how we can able to minimize the alloimmunization? So in the Western world, they also do not only the AB1 RH, they also do the extended phenotyping, verifying the antigens of complete RH, Kel, KIT, Duffy, MNS, Lewis. That's called as the extended phenotyping. So this is an article which says the transfusion related red cell alloantibodies, induction and consequences. It's like a review article. So what the conclusion is, judicious transfusion of RBCs is the major or primary strategy invoked in alloimmunization prevention. So what do you mean by judicious transfusion of RBC? It includes matching RBC antigens of blood donors to those of recipients. Additionally, they can provide this immunomodulatory therapies. So one of the important strategy is matching the RBC antigens of donors as well as the recipients. That's called as the phenotyping. So phenotyping is nothing rocket science. It's to verify the presence of expression of antigen on the red blood cells. Already we are using verifying the presence of A, B, as well as the D antigens using the anti-sera, anti-A, anti-B, anti-D. So similar like that, using the anti-seras for the other antigens like anti-E, anti-C, anti-small c, anti-small e, anti-K. So like that with the anti-seras, we can able to verify the expression of antigens on the red blood cells. Because when there is a variation between the donor and the recipient, so whatever the antigens present in the donor but lacking in recipient can lead to the alloimmunization. So phenotype matched blood, especially for those highly immunogenic antigens. So we should not introduce the additional antigens into the recipient's system. So that's the thing we say, that compatible blood units. So verify that donor is also not having E antigen. So he should receive the blood which are lacking E antigen by means of phenotyping. So phenotype is identified based on the reactions with the red cells and the specific antisera. Similar like anti-A, anti-B, and anti-D. We are all aware that RBC is having various type of antigens. So the phenotype is also designed like that. The limited phenotype, full warm phenotype, cold phenotype, and complete phenotype. Like 4 types or 4 versions. Limited means which are leading to the alloimmunization frequently. What we have seen in the earlier slides, the major number is related to the RH, followed by the M. So do only those type of antigens you verify it. Like RH, Kel, maybe you can include the M. That's called as the limited phenotype. Full warm phenotype means which are the antigens can lead to the production of antibodies which are of IgG type, which are more clinically significant. Like RH, Kel, Duffy, KIT. In the MNS, S antigens, capital S and small s. That's called as the full warm phenotype. So when there is a issue of cold antibodies, then we can do the cold phenotype, which leads to the production of IgM type of antibodies, which reacts at the room temperature or below the body temperature, the cold condition. Like M, N, P, Lewis, A and B. And complete phenotype is both warm and cold antibodies. So now, if you see that in the RH phenotyping, we usually differentiate RH positive and RH negative, only 2 types. But when you do the phenotyping, the so-called the RH positive itself can be further divided into 9 different types. R1, R1, R2, R2, R1, R2, R1 small r, R2 small r. Like that, you can have 9 different types based on the presence of capital C, capital E, small e antigens. Similarly, in the RH negative, they can be further classified into 4 types, like small r prime r double prime r, so r single prime, r double prime. So like that, we can able to differentiate between the in the D and D positive and D negative. Here we can further dividing into 13 different types by means of limited phenotyping only for the RH antigens. So this RH and Kel phenotype, which are the very common antigens which leads to the alloimmunization, more than 60 to 70% of the alloimmunization occurs because of this RH antigens. So we can do that limited phenotype of RH. That means only we are going to do additional 5 anti-sera. We are going to verify the antigens that can able to prevent the alloimmunization in about 70% of the patients. So there are cassettes are available with the preloaded anti-sera like anti-C, anti-E, small c, small e, anti-K. So we can able to differentiate what is R1, what is R2, or R1, R2. So like that we can able to, based on this phenotyping, which may take approximately less than about 6 minutes, 6 to 7, 8 minutes. We can able to do the limited phenotype of RH along with the routine blood grouping for ABO and D. That's a limited phenotyping. So here we have done one study with the donor samples. So what is the prevalence of this various one? This is about 1,454 cases. So 44% were R1, and next 30% were R1 small r, followed by 11 to 12% R1, R2, and R2R is 4.81, and R2R2 is around 0.76%. Similarly, there are multiple studies done. It's almost similar, the data. In case of RH negative, the most prevalence is small r in every study that. So in this study, the KEL positive is observed in about 1.4% cases. So in this, they also verified in which blood group, like A group, B group, AB group, O group, like similarly O negative, B negative. So similar, it's only the study that. So almost every cases you could see that the equal percentage of this R1, R2, or R1 small r. So why we have to do this? The donor as well as the patients. This was a study you have done. If you provide the phenotype matched blood units to the multi-transfusion patients like thalassemic patients, what will be the impact? So in this center, they provided the phenotype matched units to all those thalassemic patients, and they followed what is its impact when they receive only the cross-match compatible blood units versus phenotype matched blood units. So as per the literature, providing RH phenotype matched blood units to these multi-transfusion patients like thalassemia, it helps to minimize the risk and the associated morbidities of alloimmunization, like iron load or the frequency of transfusions, because initially it may monthly once, and then slowly that thing it will increase. Maybe bi-weekly we have to provide the blood units. It can also lead to other complications. So if you provide the phenotype matched units, so it can help to increase the RBC survival. That means the transfusion requirement may be little minimized. The frequency of transfusion can also get reduced. The volume of red cell units required also maybe we can minimize it. So in this centers, about 114 thalassemia cases were receiving blood on regular basis. So up to one period, they were received the cross-match blood compatible blood units, and afterwards they were receiving RHCL phenotype matched blood units. So if they have to provide the RHCL phenotype matched blood units, they have to do all the donors. Ideally, all those repeat voluntary donors, they can do the RHCL phenotyping. Once it is done, they can be kept it in the registry, and for each patient, they on rotation basis, they can able to issue the RH phenotype matched units to all those thalassemia cases. So in this centers, they followed initially 23 thalassemic patients before and after initiation of this, providing RHCL phenotype matched blood units. So what is the frequency? What is the number of blood units required if you are giving cross match or phenotype matched blood units? So it's just a preliminary study. Within the short span of time, like after issuing the phenotype matched units, either it is a 2 to maximum 6 transfusions, they could see some significant improvement in the frequency of transfusion as well as the improved survival of transfused RBCs in the thalassemic patients. So out of 23 patients followed, 18 patients showed the improvement. Reduction in the number of transfusions or reduction in the number of units, which indicates the improved survival of phenotype matched RBCs in the circulation. It requires continuous follow-up. So where there is a color shading, so there is a variations like a cross-match compatible units versus phenotype matched blood units. It needs continuous follow-up to have a better understanding. So if you go to the literatures also, there are also literatures of the study which was published in 2024. The phenotyping of RH plus and KEL blood group antigens in thalassemia and its impact on alloimmunization in a tertiary care hospital. So again, they made it like a two groups. Group 1 who received phenotype matched blood units, and group 2 received cross match compatible blood units. So what they observed compared between the group 1 and group 2, the chances of developing autoantibodies or alloantibodies and the transfusion reaction were more in group 2 who received only cross match compatible units when compared to the patients who received phenotype matched blood units, the limited phenotype matched blood units. So they have seen the significant difference in the febrile non-hemolytic reactions. So what they concluded that patients with thalassemia or any multi-transfusion patient should be typed for RHCL antigen before initiation of the transfusion, which will help in reducing the rate of alloimmunization, autoimmunization, and frequency of transfusions, and overall improved survival rate of red blood cells in those patients, which shows the importance of providing at least limited phenotype matched blood units to those multi-transfusion patients. So another important aspect is the interference of daratumumab, which is the human IG1 monoclonal antibody, which targets CD38 glycoprotein red blood cells or cellular surface of neoplastic plasma cells. So this TARA is currently used for the treatment for multiple myeloma cases. So when the patient is under the TARA, because it is the human IgG1K monoclonal antibody, which can bind to the CD38 protein, which may lead to that positive. So that can interfere in the while doing cross match or antibody screening. So these are the tests can get affected for those patients who are under treatment with the monoclonal antibodies. Nowadays, there are so many other multiple monoclonal antibodies. Human monoclonal antibodies are used for the therapeutic purpose. There are various cancer patients receive different types of monoclonal antibodies, which may also can interfere that. So how to overcome this TARA interference? How we can able to provide compatible blood units, because we cannot do the cross match which can interfere because of the presence of this TARA on the red blood cells. So in such a cases, either we have to remove those by the treatment, or we can provide, once you know that the phenotype, you can provide phenotype matched units. This was the study published in 2021. So either they have to do the techniques DTT treatment or block the CD38 antigens on the reagent and the donor red cells, or neutralization of anti-CD38 antibody, or doing the phenotyping, extended antigen typing of red blood cells and provide phenotype matched units for transfusion. So in this case also, phenotype matched units can help to enhance the safety of blood for transfusion. So doing phenotyping is not a major thing. It's a very simple procedure. Already we have seen doing the hierarchical phenotyping using the cassettes which are having preloaded anti-sera. And there are also anti-seras available for other antigens like Duffy, Kid, Amanas, P, Lewis. So we have battery of these anti-seras for doing the extended phenotyping. Some are of IgM type, some are IgG type, which can be performed within from 6 to 8 minutes at the maximum. If it is IgG antibody, it can take less than 20 minutes to do the phenotyping using the column agglutination technology. For example, phenotyping of Duffy and capital S, small s antigens. For this, the anti-seras are IgG type. So you have to do it in the 5AG IgG cassette, similar like a indirect antiglobulin test, where you have to add 10 microliter of RBC, 40 microliter of anti-sera, mix it and incubate it for 10 to 15 minutes, and then centrifuge it. The anti-sera will bind to the antigen. Since it is IgG, the red bound red cells will get agglutinated in the presence of anti-human IgG. So within 20 to 20 minutes, we can able to see the reaction. Similarly, for the other like HIT, Lewis, P antigen, the anti-seras are IgM type. So we can do like an immediate spin reaction using the BioV reverse diluent cassettes, the direct agglutination test. So add 10 microliter of RBC and the 40 microliter of this anti-sera, the cassettes, centrifuge within 5 minutes, and then you can able to read. Similarly, for M and N antigens, which are also of IgM type, which needs a less potentiator. So we need to use the IV neutral cassettes, which has got very low concentration of polyethylene glycol. Similar like other one, within 6 to 8 minutes, we can able to identify the presence of M and N antigen on the RBC. So add 10 micro RBC and 40 microliter of antisera in the neutral cassettes, mix and centrifuge it and read. So phenotyping can be done, even extended phenotyping can be done within 20 to 25 minutes. So also one of the study published in 2022, what they have shown that when you are doing the phenotyping of the donors, it helps in multiple ways. When you want to do the differential absorption studies, when you are not having the autologous red cells, we can use R1, R1, R2, R2 and smaller cells for the differential absorption study. So in such a conditions, when you do the phenotyping, you know that you can able to identify your own donors who are having R1, R1 phenotype, R2, R2 phenotype, and smaller phenotype that can be used for the differential absorption in case of DAT evaluation. Also, you can able to have a data bank for multiple advanced immunohematological studies like anti-G differentiation. So you can have the registry with the known antigens. In future, you may also be able to develop the indigenous cell panels for doing antibody screening and identification. These are the additional advantage of doing hierarchical phenotyping or the extended phenotyping in case of voluntary donors. You can have the registry. So what are the pros and cons of doing this phenotyping? The pros, if you consider that, okay, when you provide RH, like a phenotype matched blood units, we can able to minimize or prevent this alloimmunization. It can help to reduce the formation of new red cell antibodies, even in those patients who are already alloimmunized. So you can have the improved transfusion compatibility. So minimized transfusion reactions. The so-called delayed hemolytic transfusion reactions can be minimized. We can also have better outcomes in the chronically transfused patients like beta thalassemia cases or sickle cell anemia cases. So less hemolysis, longer survival of red blood cells, so reduced transfusion requirement. In case of sickle cell anemia cases, so it can avoid delayed hemolytic transfusion reactions. If mother is required a blood, so we can prevent alloimmunization for the childbearing mothers, which can help preventing the hemolytic transfusion, hemolytic disease of fetus and newborn. And in case of complex cases with multiple antibodies, or in case of multiple myeloma cases with who are undergoing treatment for DARA, we can have better planning for the transfusion. So ease future transfusion by providing the phenotype matched units. So these are the pros or advantages of providing phenotype matched units. When there are certain advantages, there can be some disadvantage also. Yes, what are the disadvantages or the cons of providing phenotype matched units? Additional testing required. Yes, we have to do along with the blood grouping, you may have to do the phenotyping. So it's an additional test which needs the required anti-seras for doing the phenotyping. So cost implications. So we have to spend money for additional anti-seras or the testing time. Sometimes, okay, after doing that, there can be a chance of limited availability of rare phenotypes. Like we have seen that R2, R2. The percentage may be low. So if the patient is R2, R2, so providing C negative blood is very important. So sometimes that can lead to the limitations. So extended phenotyping is not always available for everyone, especially in the countries like India, low resource settings. So you need the resource, we need the infrastructure, well-trained staff doing the phenotyping and interpreting, and which units has to be given to which patient. And we need to have the good record keeping. So instead of saying, okay, only A types, A positive, A negative, B positive, B negative. So maybe additional things are required. So the registry, the documentations, that all, it needs a little resources, either human resource as well as the infrastructure resource and the reagents requirement. These are considered it as the or the disadvantage of providing phenotype matched units. But always the advantage can overcome these disadvantages. So in conclusion, providing at least the limited phenotyping like RHK phenotype matched units during transmission is essential to prevent alloimmunization at least in about 70 to 75% of the cases, which helps to enhance the overall safety and efficiency of transfusion process. So in case of multi-transfusion cases also, phenotype matching ensures the transfusion blood components function optimally in the recipient body. Okay, we are expecting at least 30 to 60 days it should survive. Yes, we can expect that. Red blood cells from a compatible donors are more likely to survive and perform their oxygen carrying function effectively, which can help to reduce the frequency of transfusion also and prevent alloimmunization. So with that, I would like to conclude the session. As a transfusion medicine practitioners, you are making difference in the patients because there is a requirement of blood in every second a day. So powering the healthier future for all those patients who need the blood transfusions, it all starts with you. Starts with the product what you are providing. Because you are manufacturing the miracle drug, the blood and blood products. It cannot be manufactured by a manufacturer as an issue. It has to be done by the transfusion medicine professionals. So we at Quiedel Ortho having a wide range of solutions to provide complete solution for the blood centers to support in your endeavor of providing safe, compatible blood and blood components to the needy patients at the right time. Thank you very much for giving the opportunity. So if there is any questions, I'll be happy to answer the same. Thank you.
Thank you, sir, for giving that elaborate and very simple also. Like it was very, I feel it would be very useful, especially for the postgraduates to understand the importance of phenotyping. As we all know, we all do cross matching and compatibility testing and all. So this is an extra layer of safety by which we can do phenotyping, especially in the repeatedly transfused patients. So if there are any queries, you can either type in the chat box or maybe raise your hand so that we can unmute. You can ask. So in this context, if you would like to just talk about the reference testing center also may be useful because we have around 75 participants from across India. So maybe if possible, they can know about that.
Yeah. Thank you. Thank you, Dr. Vik. Yeah, see,
Yeah.
everyone may not have all the required reagents, but it doesn't mean that it should hamper their safe transfusion purpose. That so we have established the reference testing centers across India. There are total 9 reference centers are there. For Kerala, we are having it at the Jubilee Mission hospitals, where you can get any complication cases. It can be like a blood group discrepancy or discrepancy in doing the compatibility testings, or to identify the antibodies or providing the phenotype matched units. You can get the help from the this reference testing centers like Jubilee Mission at no cost. Only thing you have to get the details of the patients and provide the samples sent to Jubilee Mission in Kerala. If it is in Tamil Nadu, you can send it to Apollo Hospital, Chennai, or Rajiv Gandhi General Hospital, Chennai. In case of Karnataka, you can send it to Rotary TTK Blood Bank, Bangalore, or Kasturba Medical College Hospitals, KMC, Manipal. In North, we are having it in Medanta, Gurugram, STMH, Jaipur, Kiranandani Hospital, Mumbai, also Apollo Hospital, Calcutta. So you have a range of centers. So if you find any difficulties, you can reach to them. You can connect with the transfusion medicine experts in those centers. You can send the sample for additional advanced IH workup. At free of cost. If there is an emergency, you can mention it. You can connect with them, get their expertise, advice, so that the patients get benefited out of it. So these
Okay, sir.
reference testing centers are well equipped with the required reagents, and they have the expertise in the field. Yes, sir. Over to you, sir.
Yes, so that's a great initiative from Quiedel Ortho. We have one participant, Dr. Satyam Arora. Can you unmute and ask the host?
Yes. Yeah. Hi, Dr. Chiramraj. It was actually a very good presentation. I mean, there is nothing to add. There is just one point that what I felt, if just to have your thoughts on it. There's been a recent paper in Blood Advances, and in which paper they had actually discussed 40 cases where they have provided RH and KEL matched units. And on a follow-up, out of I think 40 patients or 30 patients, 13 developed alloantibodies against RH and KEL. So that's a very interesting new finding. Another just a word about HLA mutations. as far as the thalassemia patients are concerned, there are some mutations which make a patient more of a responder as compared to few of them who are not a responder. And when there is a patient who is a hyper responder, they do end up making alloantibodies, even providing them, with a phenotype matched. Yeah, just to maybe have your opinion on it.
Yeah, I think good observation that. Now, I have not gone through that paper, but they have given explanation that why, even though they received the blood which are not having those
But
antigens, but
there
still
was
they get
some,
alloimmunization.
yeah,
Any
there was
specific
some epitope, mutations.
epitope mutations were there? Okay,
Yeah,
okay,
yeah.
okay, okay. Because in one study, whatever, then we couldn't see anything. There is no any new alloimmunization we observed, and also it's a continuous follow-up is going on that. So maybe let me also go through that and then see.
Yeah, I'll
Maybe
just
it's a new findings. Yeah, that is
maybe I'll just look for it again, and if I get it in time, then I will just put it up in the chat box as well.
sure, doctor.
Okay, thank you.
Something like new powers brings in new challenges also. So, so if anybody else has any queries, I think there are no more queries in the chat box also. So thank you, Dr. C, for your extensive talk. And back to the hosts.
Thank you, doctor. Thank you all.
Thank you all for joining today's webinar. Your feedback means a lot to us. The feedback form link is now available in the chat, so please take a moment to fill it out before you leave. Thanks again to our speakers and attendees. We look forward to seeing you at our next event. Take care.
Bye-bye.
Thank you. Bye.
I already told sir कि सर मतलब मैंने बोला सर को मैंने कहा सर हमें से कोई भी नहीं जाएगा तो ऐसे मैम JR2 JR1 की कॉल साथ साथ लगेंगे तो JR2 के बहुत सारे कॉल आ जाएंगे JR2 JR3 500